Hi, I'm Alan Moses. I'm the inventor of the Moses Oral Sleep Apnea Appliance and X-Slant, the gold standard bite registration guide. In this video, I will explain the concept of oral airway nirvana and how it affects the practice of sleep dentistry. The premise of my scientific paradigm for dental treatment of obstructive sleep apnea by use of an oral appliance is based on the fact that there is a fixed, stable position for each patient of maximal oral airway dilation and stenting, and I call this oral airway nirvana. Oral airway nirvana is based on four concepts: multidimensional movement, avoiding slant, which we'll explain in a bit, and relates to elevator muscle squeeze, accommodating CANT, which we'll explain as well, and it allows asymmetric shift, which is important, and X-Slant, a bilateral molar stabilized bite registration guide, is the indispensable requisite to achieve oral airway nirvana with a sleep appliance. Oral airway nirvana, or optimal biofacilitation, is a fixed position of the oropharynx, definitely beneficial during sleep, but sleep is a subconscious state, not a position of normal oral function. A human being may function consciously at this position during athletic events to enhance optimal oxygen intake, in which case they are in autonomic sympathetic dominance, but it is not a position of everyday normal oral function. Dental sleep clinicians determine the oral airway nirvana while the patient is awake and register it for construction of an oral sleep appliance. Oral airway nirvana is the result of multidimensional movement. This is a CT scan of me and what multidimensional airway looks like on a CT scan. On the left, it shows the airway in functional rest position, and the right side shows the airway with the Moses in place, and it demonstrates dilation, multidimensional airway movement. In jaw opening, the TMJs move from a position of centric occlusion to a teeth-apart position out of the glenoid fossa by rotating slightly forward, simultaneously gliding downward anteriorly and laterally, while remaining under and against the articular discs along the temporal bone eminentia. This complex mandibular movement is guided by the neuromusculature, restricted by the rigid nature of the bony architecture, of the hardness and of the articular discs, and the inherent asymmetry of the condyles and fossa. The normal temporomandibular joint movement necessary to achieve oral airway dilation consists of bilateral spheroidal and concave parts moving smoothly and quietly against each other. Natural neuromuscular movement to physiologically alter oropharyngeal airway dimension is limited by the interaction of the hard skeletal parts of the temporomandibular joints. This is important. But this is Dr. Eloy de Bruhl, my professor of anatomy at the University of Illinois about 50 years ago, but world famous and eminent in his field. The temporomandibular joints cannot and do not move in only one linear direction, anterior, vertical, or lateral. Their movement is always multidimensional and never naturally unidimensional. Coordinated, complex multidimensional movement determines the position of bite registration. Interarch jaw position varies depending on the biological function being carried out. Each different biological function utilizes different combinations of muscle activity and different muscle pressures. Each person has a unique combination of facial features and facial muscle alignment. The human mandible is a single bilateral bone, not a simple hinge like other animals have. The human mouth has an extended range of motion and functions: mastication, breathing, swallowing, incising, speaking, screaming, separating food and liquid from airflow to prevent aspiration. Oropharyngeal nirvana is a very complex anatomic position. It's a stable position, though, achieved by coordinated positioning and movement of the mandible, pharynx, hyoid bone, head posture, nasal competence, and tongue posture. A bite registration must capture the result of natural, smooth, complex, coordinated, multidimensional movement of numerous parts. Oral airway nirvana is the result of complex anatomic movement. To maximally stent the oropharyngeal opening and correctly position the tongue muscles function as part of the pharynx. The hyoid bone floats like a pulley amid the 12 muscles that move the pharynx. The hyoid bone attaches to the hyoglossus and middle pharyngeal constrictors. The mylohyoid and hyoglossus muscles work in synchrony to maintain the normal hyoid bone position. Hyoglossus retracts and depresses the lateral borders of the tongue. In oral airway nirvana, the dental arches within the mouth are reset to increase volume of space for the tongue. Hold the tongue forward from the soft palate and pharyngeal opening. Increase the volume of airway above the epiglottis. Oral airway nirvana is achieved by a complex multidimensional rearrangement of all soft tissue parts within the oropharyngeal apparatus. In simpler terms, at least 7 structural movements result from the complex multidimensional coordination of the hyoid bone, vertebrae, tongue, pharyngeal, and neck muscles. What an oral appliance bite guide should do: create space, optimal space for the tongue in the mouth, advance the tongue anteriorly, advance the mandible anteriorly, stretch the hyoid muscle, lower the mandibular position, advance the hyoid bone anteriorly, and change the alignment of some of the orofacial muscles. Let's talk about shift. Human beings may be thought of as bilaterally symmetrical. Dentists doing craniofacial evaluations consistently note higher eye, higher ear, higher shoulder, slanted nose, and the reality is that human faces are most often asymmetrical, and their jaws move asymmetrically as well. Okay, a seminal study by Moses et al. Demonstrated that 95% of human condyles are asymmetric relative to a sagittal plane, defined by the contact between teeth numbers 8 and 9 and the middle of the anterior border of foramen magnum. So you see that when you look, the computer prints it out, when the CT registers it, you can see, based on these yellow arrows, that the condyles are usually asymmetrical relative to the skull. Moses also demonstrated that anterior condylar protrusion at the level of the maxillary incisors is usually asymmetric by 5.36 millimeters. Intercondylar asymmetry is the normal state in human beings. Looking at this picture of the skeleton, you can see that from the middle, they curve as you protrude out. They usually curve, averaging 5.36 millimeters in 95% of human beings. Or this slide shows 4 pull-forward positioners whose protrusive trajectory is mechanically directed on an arbitrarily determined straight linear midline plane. Bite registration devices that mechanically restrict protrusive movement unidirectionally along a midline cranial plane do not have a sound scientific basis. There is little or no substantiating scientific literature that optimal airway dilation occurs at a forced, mechanically directed position, arbitrarily determined as upper midline over lower midline. The predetermined midline protrusive position of a pull-forward bite registration guide is not consistent with natural jaw movement. Natural jaw movement is multidimensional. The mandible never moves naturally in a straight linear trajectory in any direction, not anteroprotrusive, vertical, or laterally. Pull forward bite registration guides misdirect protrusive movement as much as 95% of the time. Natural physiologic mandibular movement mandates a bite registration guide that records natural, asymmetric, physiologic jaw movement. And of course, that device we're going to talk to you about is X-Slant. Now we're going to switch over and talk about slant. In an anterior stabilized interarch jaw position, an acute angle between the upper and lower arches is defined as slant. This angle here between the red lines is called slant. Human anatomy related to slant. The powerful elevator muscles of the body, human, whose focus of contractile function is at the posterior of the mouth. None of these forces occur at the anterior of the mouth. Elevator muscle squeeze is the explanation of slant. And we're going to talk about what is elevator muscle squeeze. And there's the same skulls. And what happens is when a patient is instructed to close on an incisor stabilized bite, you see the blue bites in the front of the mouth, slant happens because there is no posterior resistance to the combined overpowering force of the elevator muscles. Slant is natural. Slant occurs. You weren't taught about this in dental school, but it is reality. Slant is a natural sequelae of incisor bite stabilization. The deleterious effect of slant is posterior mandibular overclosure in the back of the mouth. The consequence of posterior mandibular overclosure is a reduction in oropharyngeal dilation and stenting. Look at slant, 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 slant. All of these anterior bite guides produce slant. Slant is an iatrogenic dysfunctional position. You don't want this. The good news is slant is avoidable. Molar stabilization results in parallel interdental arches, which gets you greater stable dilation of the oropharyngeal airway. It's bigger in the back here than it is in the back here. That's because you need to take the bite from the molars so you don't have elevator muscle squeeze generated into your bite. So we've gone from shift to slant, and now we're talking about cant. Occlusal cant is defined as the vertical alteration in the upward-downward rotation of the occlusal plane in the frontal plane of one side over the other, or sagittal deviation of the maxillomandibular interarch relationship from centric occlusion. This is the book definition. You'll see it in just a moment, and it's very clear. Canting of the occlusal plane can originate in the maxilla or the mandible. Sleep dentists must have a bite registration guide capable of factoring cant into their sleep appliance positioning. Okay, this is what it looks like. CANT. Canting is not a diagnosis, rather a symptom or a condition that relates to a specific etiology. Orofacial asymmetry is a significant condition to note on examination. Factor to be considered in bite registration for an oral sleep appliance. Zhang, in a study of patients with orofacial canting and mandibular deviation, reported asymmetric palatal-pharyngeal, glossopharyngeal, and hypopharyngeal airway dimensions. This reference is down below there if you care to copy it. Let's look at a case study. The main problem here is obstructive sleep apnea. The patient clearly shows visible orofacial canting, as you can see the picture on the far right. He is compliant with CPAP. He reports that it decreases his subjective daytime sleepiness, but based on a polysomnographic study, his sleep physician told him that CPAP was unable to get his AHI below 15, and the prescription was supplemental use of an oral sleep appliance to reduce the apnea-hypopnea index. The patient also reported that he was only able to chew on the right side at his initial consultation appointment. So this is interesting. We got to deal with that. Using a bilateral molar stabilization guide, as you see, the X-Slant here, neuromuscular balance was achieved, but the vertical dimension on the right side was 5.5 millimeters, and the vertical dimension on the left side was 6 millimeters. You can see the circles, and that shows you the different thicknesses of the shims that were used to give this guy a balanced bite where he hit evenly on both sides. Practicing at a reasonable standard of care mandates factoring the orofacial canting into the bite registration for a sleep appliance. A bite registration guide using bilateral molar stabilization uniquely addresses interarch asymmetry. Bite registration guides based on incisor stabilization cannot capture unilateral vertical posterior interarch discrepancies, period. With that, you get a pop quiz. Patient presents with this CT scan on the right and a prescription from a sleep physician for an oral sleep appliance to treat obstructive sleep apnea. The patient could not tolerate CPAP. So which type of bite registration do you believe is indicated here? Anterior incisor stabilized or posterior molar bilaterally stabilized? Look at the difference between the condyles on the right and the left. That gives you your answer. Okay, if you're still with me, you must have gotten the pop quiz right. The bite registration guide for establishing the position of oral airway nirvana optimal biofacilitation is of paramount importance. It must be done using a bilateral stabilization guide capable of recording such factors as vertical, lateral, protrusive. It must accommodate asymmetric movement or shift. It must register normal, smooth movement between the structurally convex and concave parts. It must achieve parallel interarch molar planes. It must avoid elevator muscle squeeze and avoid cant and slant or correct them. Must be also capable of compensating for what you saw earlier, unilateral interarch vertical discrepancies. There's only one bite registration guide available capable of establishing all these factors, and that is X-Slant. Summarizing, incisor interarch stabilization is a scientifically flawed concept. It produces slant via the elevator muscle squeeze. Slant may over-open the anterior to gain the proper vertical height, and the sequela will be open mouth and mouth breathing. Can't close the lips if it's too wide in the front. Open in the front. Slant diminishes posterior oropharyngeal circumference and reduces airway patency. The normal position of the hyoid bone is changed. The greater cornua of the hyoid bone are depressed. The head position of the spinal column is altered. And elevator muscle squeeze on the TMJs place them in suboptimal biofunctional position. Got to go back to look at slide 3 or 4, I don't know, earlier. Unilateral incisor cannot register or factor a unilateral interarch vertical discrepancy. That's also, you'll see that's the patient who chews on one side. You saw that in the CT scan in your pop quiz. Incisor stabilization may be easier, but it's a scientifically flawed concept. Bilateral molar stabilization, a la X-Slant, eliminates slant, superior tongue position relative to oropharyngeal opening, parallel interarch alignment, lowers the mandibular position, physiologic positioning of the hyoid relative to the neck and tongue, excellent physiologic conditioning of the mandibular condyles, discs, and glenoid fossa. It can compensate and correct unilateral discrepancies in interarch vertical height. X-Slant, multidimensional, strong scientific basis. It's easy, cheap, scannable with digital scanning and disposable. Finally, the conclusion. Now that you understand the complexity and the importance of oral airway nirvana, you realize it can't be achieved by arbitrarily pulling or pushing by using unidirectional erector set parts. Now that you understand the concepts of CANT, slant, shift, and elevator muscle squeeze, and the iatrogenic flaw using incisor or anterior stabilized bite registration guides, you realize the imperative to use X-Slant bite registration guide. Thank you for your time and attention. Any questions, please, if you want additions or subtractions, I will address any questions by email, alan@themoses.com, and thank you again.